Yep. Okay. Excellent. Welcome, welcome. My name is Carrie Neiman. I am one of the core faculty members here at the Cochlear Center for Hearing and Public Health. And I am really excited to be here today for our next part of our seminar series featuring Matt Bush, which I will introduce a little bit later. Before I get too far, I just want to cover a couple logistics. So we do have Q&A, please, for everybody who's joining us online. Use the Q&A feature. There is no chat, but the Q&A feature is monitored, so please don't hesitate to put your questions there. Closed captioning is available, and the transcript link is in the messages as well. If you have any technical difficulties, please feel free to reach out at the email address there. So here we are in terms of January 22nd and Matt Bush, who's joining us. If we look ahead for the next couple of sessions in our seminar series, February 19th will be our next edition. Charlotte Yeh, who may recognize her from her work with AARP and a past speaker in the seminar series, but now who is working a little bit more in the industry side of things. So will be bringing us a bit more of an industry perspective, and rumor has it that there will be some nuanced hearing aid glasses that may be able to try out. So exciting for those who are able to attend in person. And then we have Dr. Amlani, who's president of the American Academy of Doctors of Audiology, who will be joining us as well. So really excited about the couple remaining seminar speakers for this year. And then as we always wrap up our year with the Cochlear Center Research Day, which is set on Friday, April 17th from 9 to 4 p.m., our keynote speaker is Malaz Bustani. So continuing a little bit of our emphasis on dissemination and implementation science, we're really excited to have Dr. Bustani join us. So with that, I will go ahead and introduce our speaker for today. So Dr. Matt Bush, he is current chair of the Department of Otolaryngology, Head and Neck Surgery at the University of Kentucky. He does hold the University of Kentucky College of Medicine Endowed Chair in Rural Health Policy. He earned his MD from Marshall University School of Medicine in West Virginia. He completed his otolaryngology residency at the University of Kentucky and his postdoctoral research fellowship and his clinical fellowship in otology, neurotology, cranial-based surgery at The Ohio State University. He then went on to do his PhD and his MBA at the University of Kentucky. He is very much a recognized leader nationally and internationally in the space of hearing health disparities, and really was at the forefront of bringing dissemination and implementation science into hearing healthcare. There are many, many different things and awards, grants, whatnot, that Dr. Bush has received over the years. But I really can't think of a higher honor than what he received in January 2025, when he received really one of the highest honors that's bestowed on a U.S. Scientist in terms of engineer, early career-wise from the U.S. government, which is the Presidential Early Career Award for Scientists and Engineers, and was one of the individuals recognized in 2025. He will also be inducted into the American Society for Clinical Investigation this year. He'll be taking over Chief Editor-in-Chief of Otology and Neurotology. So just some of the recent accomplishments of Dr. Bush. And it is an honor and a pleasure to have you here as a colleague and a friend to take your time and share more about all of your amazing work thus far and to come. Thanks so much, Matt.
Good afternoon. Thank you, Carrie, for that very kind introduction. It's a pleasure to be with you, and I look forward to talking with you a little bit about enriching clinical research in hearing health as dissemination and implementation science can be integrated in with a hearing healthcare research portfolio and interests. These are my disclosures. I will not be discussing any off-label treatments or devices today, and my research has primarily been funded by the NIH through the NIDCD through a variety of different funding mechanisms. These are our objectives today. First of all, I just want to discuss some key concepts regarding dissemination and implementation science. I realize there may be a wide range of knowledge about what D&I science is and how that can take a place in your research activities. But I'll talk to you kind of from an elementary level as well as give you some examples. But we'll talk then about some design considerations in research as you think about clinical research and how D&I science can pair with it and strengthen it and enrich your research activities. And then lastly, I'll summarize some practical examples of hybrid dissemination implementation trials with clinical trials to promote timely hearing healthcare from my experience. Um, this is a very important disclaimer, is that I know enough to be dangerous in D&I science. So I'm coming to you from a clinician's perspective. I'm clinically trained as an otolaryngologist. D&I science isn't anything that I ever heard about in medical school or in residency or fellowship, or really at any national conference that involves the congregation of otologists and neurotologists. But I realize as I've been involved in the field of health equity and health inequity research that D&I science is a critical part of how we think about conducting meaningful clinical research. So I do serve as a stunt double for a D&I researcher. But I have found that some of the training opportunities that I've been exposed to, either during my K Award in career development activities or as a funded independent researcher, have really made D&I science not only seem appealing, but really seem absolutely mission critical to my future in health equity research. I was an attendee of the 2014 Summer Institute on Randomized Behavioral Clinical Trials. This was supported by the NHLBI and focused on behavioral interventions and how do you design clinical research interventions and clinical trials involving behavioral interventions. And D&I science was a part of some of the content. Furthermore, I attended what was called TIDER at the time, the Training Institute for Dissemination and Implementation Science, which was supported by the NIH. Basically was like a boot camp for D&I research. That specific type of boot camp doesn't exist anymore. There are some other training activities that I'm going to tell you about at the end of this talk that you might find meaningful, that you may want to explore. Um, there's nothing like getting involved in the weeds in grant writing that really causes you to expand your knowledge base as well as push you outside your comfort zone to try to be relevant, to try to be fundable. And D&I science was really important ingredients for both of those. And then lastly, just pure collaborative research and conversations formalized my interest and involvement. So maybe I feel in some ways like an imposter and outsider, but I think I've been very welcomed and very much encouraged by fellows that are involved in D&I work. A concept that I want to present to you that at D&I will be applicable for is about bridging new gaps. What I've shown you here is the New River and the New River Gorge and the New River Gorge Bridge, which is near Fayetteville, West Virginia. So I grew up in West Virginia. I have kind of some rural roots, backgrounds, and this is one of the reasons, just from my upbringing and the places that I've trained, that has made rural healthcare and rural research, rural health research, an important part of my life. But the New River and is an amazing place. This region of West Virginia is just a playground for camping and hiking and kayaking and all kinds of outdoor activities. So wild and wonderful is certainly this region of West Virginia. But in the fall, there was a event known as Bridge Day, where some thrill seekers, this bridge would be closed down, and thrill seekers would jump off this bridge with parachutes or hang gliders or a variety of different floating mechanisms to try to make it safely down into the gorge. Not an event my mother ever let me attend and certainly never participate in. But when you drive across this, when you see this gorge, it's really unbelievable. And this, engineering miracle to create this suspension bridge, or this bridge that involves, bridging this giant gap, is really an amazing feat of engineering. And it's interesting that this new gap is in parentheses. The New River is actually not new. It was new in surveyors of this region of Western Virginia at the time and was referred to as the New River. But the New River is felt to be actually probably one of the oldest rivers in the world, and certainly in North America. So this giant gorge that's here in this ravine, felt to be formed by this river over the course of time is really dramatic. But when you stand and, on one side of this to look at the other, it's so difficult even just to see the other side, to see any sense of clarity or how to get across if it were not for this bridge. So this new gap, this new problem is not a new problem. And when we kind of apply this analogy to thinking about on one side of the gorge is novel research developments, interventions, innovations that we come up with in our own research labs or collaborative teams. We want to apply that for clinical practice, implementing it into clinical practice to change population health. We want to influence policy change to promote health. But really, it does seem like an unbridgeable gap or gorge, which is not a new problem in any sense. And so this is the challenge that we face. When I think of hearing healthcare and the hearing healthcare gaps, I look at some of the experiences and some of the work that we've done in rural communities. When you ask yourself what gaps exist, there are certainly delays in pediatric hearing loss diagnosis. Well over a decade, we published some research in Journal of Pediatrics that described that after infants are screened in a newborn nursery within a hospital, and they fail that screen, only about 20% of rural infants, are no-shows to follow-up. So that no-show follow-up rate is really concerning for rural population. And unfortunately, these delays and disconnects result in rural infants taking 2 times longer to obtain a diagnosis of hearing loss. Furthermore, there are delays in pediatric hearing loss treatment that represent a major gap within this field. That some research that we've published has demonstrated that children that have hearing loss that come from rural communities take 2 times longer to get the appropriate treatment of hearing aids, or 2 times longer to get a cochlear implant compared with their urban counterparts. Once a child receives a cochlear implant, there are still ongoing gaps in pediatric cochlear implant care. Those that live in rural communities, these children that have cochlear implants within these communities, face longer distance to their audiologist or their speech language pathologist. They have limited access to speech therapy within their local community, and they have a higher likelihood of having device failure, device problems, and being without sound from their device. Unfortunately, these are gaps that are very difficult to address. And some families, when they ask me as a clinician, we don't have a speech language pathologist or an audiologist within our county or any contiguous counties. What should we do? And unfortunately, sometimes the advice is you need to move. You need to change your address. And that's a terrible thing to say. I'm not a real estate agent nor a trusted family friend. I'm a provider of hearing healthcare. But even if telehealth is not available within their community, they need to consider a change of their zip code. So these are some challenging gaps that children are facing in the hearing loss world. Furthermore, what about children that are dealing with otitis media, specifically chronic suppurative otitis media, a more destructive and potentially life-threatening form of otitis media, that children face huge gaps in chronic otitis media care. Children that have Medicaid, that have this condition or this form of otitis media, are more likely to have no-show appointments for their surgeon visits before or after surgery. Furthermore, they're less likely to have an audiogram or hearing test after their surgical procedure to deal with the disease, which is really important, meaning that they may never get a hearing aid to address any hearing deficits after they've been treated surgically. And interestingly, children that come from rural communities that have this form of chronic suppurative otitis media have 3 times higher odds of cholesteatoma, which is a condition that is destructive to the bones of hearing and can even be life-threatening. So a more invasive, a more damaging form of this otitis media within these rural communities. In the adult population, we also face some very similar gaps that need to be bridged and addressed, such as delays in adult hearing loss treatment. When you look at a rural adult utilization for either obtaining a hearing aid or obtaining a cochlear implant, on average, it takes about 7 years longer for a rural adult that has a similar form of hearing loss or progression of hearing loss to obtain either one of these types of devices. And this is really controlled for age and other factors, and basically is more related to their geography and perhaps some of their knowledge or lack of knowledge of hearing healthcare and healthcare resources. So, what's the answer? Well, let's just find a quick fix for these problems. I don't mean to be glib or comical about this, but of course we know and understand that none of these things are quick fixes, and these aren't very easy things to address. When we consider overall, just in biomedical science, the pipeline of producing and vetting research to get into and to change evidence-based practice is not a quick problem. It is not a quick fix. It's about a 17-year odyssey of this funnel that begins on the left side of the screen with our priorities of research funding, that we actually get a research grant funded in one step, and then move forward with publication priorities and peer reviews, research synthesis, and then development of guidelines based on a number of studies that provide evidence to change care. And then you move all the way to the right, to the end of the funnel, and get into practice. It may be a multi-year or multi-decade journey to be able to change practice. Meanwhile, there are individuals that are in our cities, that are in our countryside, that are facing huge gaps, and they're struggling and suffering today. So we don't want our research to be very focused and context being ignored. Unfortunately, we often have this dichotomy of research to practice that creates a real challenge. We often are operating as researchers in the gray shaded region of this figure, where we define a problem, we identify causes, we develop and test interventions, and then we go back to the drawing board and redefine a problem and re-identify causes and redevelop and retest interventions, never actually being able to move that translation of research into practice. Furthermore, there's challenges from the bottom side of this graph, or this figure, of adoption and widespread use and knowing how to do that. So some of the problems that we face with clinical research is the lack of attention to large systems context and how we consider the research that we're doing in controlled environments, how it may apply to the more complicated real-world scenarios. Furthermore, we struggle with understanding the real details that are necessary in implementing research into actual practice or into health systems. We may lack a relevance to the real world and to individuals that are within the real world. Do community stakeholders, do people in the community understand and trust research interventions or new developments that may come through research? We're at a very dangerous place in the history of scientific development and innovation, in that science and scientists are being attacked and questioned as being invalid and really out of touch with real world. And unfortunately, much of our clinical research focuses on a single intervention. Because of our controlled scientific method approaches, we focus on removing all of the variables and controlling for all of the variables to isolate the intervention to cause a particular clinical effect. And unfortunately, many problems like hearing healthcare access or utilization may need a combination of interventions and not just one particular single widget or intervention to fix the problem. What does that lead us to do when we ignore all these things or lack all of the relevance in these different areas? Is that we have inadequate information to set a clear direction across a range of populations. Perhaps our intervention works within our academic medical institutions, but what about in a rural primary care setting? Does this intervention work in the same way, and is the uptake the same? We may lack evidence for this broader scale effectiveness. We may have difficulty funding or publishing research on community, environmental, and policy-based prevention initiatives, and have a lack of generalizability of our research and results to other populations. So to bring us back to the New River Gorge and the New River Gorge Bridge, I propose to you that D&I science is not the quick fix or the answer to all of these problems, but it can help address some of these things that I've brought up to help us to bridge that gap between all of the good things we're doing on the left that is filling our time and filling our CVs and research labs, and moving those across to where we want our research to land, true impact, changing healthcare, changing policy, and changing practice. So now that I've given you kind of an introduction of why we consider D&I science, I want to talk to you a little bit about the key concepts that help define D&I science to address these gaps. Again, if there's anyone in the audience who is an expert in D&I science, give me a pass. Don't fillet me before everybody, but I'm going to try to, in a general sense, lay out the field so that it's somewhat understandable and somewhat meaningful to you. So D&I science is a different type of research. It's the focus of this research is about moving translation, taking research discovery and moving and implementing research or disseminating research to be more effective for a broader population. And the goal is to be more relevant to a wide range of stakeholders. There is a challenging interface between research and real-world application, and that's what D&I science is about bridging, which takes into effect multiple contextual factors as well as multi-component programs or policies. This type of research often is nonlinear, and it is transdisciplinary, involving multi-level and multi-methods. And in a real sense, this box on the yellow helps you to understand the why behind this is that messy real world problems like hearing healthcare delivery requires pragmatic attitudes of finding solutions in active collaboration with stakeholders. This is a real mantra or a spirit that helps to drive D&I science. Implementation science is really defined as the process of putting to use or integrating evidence-based interventions within a specific setting. Taking an intervention, for example, from an academic practice and perhaps implementing that same intervention into a rural Appalachian primary care setting. That would be an example of how we might study this implementation process and how implementation science can inform that. Perhaps we need to adapt the intervention. We don't want to change it, losing the key ingredients, but maybe we have to adapt it. D&I science can help us with adaptation. Maybe we need to understand the broader factors and the contextual issues that surround a rural Appalachian practice that's very different from an academic practice in maybe a specialty clinic like otolaryngology. And D&I science can help to study and measure some of those contextual factors. And the reality is that this implementation work can be, really moving your research out of the academic environment into the real world setting. One thing I want you to note is in the italics here that it's about evidence-based interventions. Maybe you're thinking to yourself, well, we're still trying to develop interventions and we're wanting to kind of figure out what's the right type of intervention to then do an implementation study on. You don't have to wait until your intervention is the best thing since sliced bread. You don't have to prove that it saves everybody's life and gives them, a big bag of money at the end of the study. you can still study your intervention while you're doing implementation research. Those are called hybrid trials, which we'll talk about towards the end of the presentation. So don't tune me out just because you think, hey, I'm already doing work where I'm not sure the evidence base of our respective or interested intervention is really that well established yet. That's okay. You can integrate both together while you're doing the work. Dissemination is more about an active approach of spreading evidence-based interventions to the target audience via predetermined channels using planned strategies. And this is more about broader spread of this type of research intervention. For an example, taking an intervention in rural Kentucky practices and disseminating that type of intervention nationally into all of rural primary care, maybe through some common networks or common channels. That might be an example of a broader dissemination, whereas implementation, you might think about, I've changed the clinic type or the population or the different environment, and I want to study the process. D&I research does indeed fit within a broader portfolio of research activities and clinical research. Think about this, and this doesn't always have to be a linear pathway, but we often are considering our research in the bottom left side of this graphic of pre-intervention studies or pilot studies, then moving into efficacy studies in which we try to control every possible variable, but yet involving human subjects or participants. And then we may even conduct an effectiveness study in a broader scale or setting. But dissemination implementation will further inform the exploration of how we do that in new settings, or adoption or implementation process, sustaining or scale up. Those are other factors in which D&I science can inform us. Kind of a side-by-side comparison of how we might think about designing and what we're measuring in different types of clinical research versus implementation research. In the middle column, you see if we're trying to think about different features of clinical research, we might look at our primary outcome being a health outcome. What is the change in blood pressure? What is the change of their decibels? What was the likelihood that they actually followed up for a clinic appointment as a behavioral outcome? All of those are clinical outcomes. Implementation might look at the care process, or perhaps the fidelity of how the intervention was developed, or the adoption, how many of the individuals that were recruited actually received the intervention of study. The unit of analysis in clinical research is often the patient or the participant, whereas the unit of analysis or perhaps randomization might be the study site or the clinic or even the clinician. Clinical research involves formative evaluations sometimes, but it's often that we're doing this during implementation research, process evaluation, occasionally within clinical research, but very much ingrained into implementation research. What types of things do we measure? What are the outcomes? Sorry for the small font, but these are a variety of different types of outcomes within D&I science. And I think when you look at this list, you won't feel that much of an outsider to D&I research, because you say we already measure this stuff or care about this stuff or include this in our research protocols. So maybe you're a closet D&I researcher too, and that's okay, because this is a place of safety and acceptance. So these are some of the things that we think about, and there are different types of tools or instruments, whether that would be qualitative or quantitative measures, to be able to evaluate things like effectiveness. That matters in clinical research, but it also matters in D&I research. How about the process, the saliency, the safety, acceptability, cost effectiveness, appropriateness, reach, intensity, satisfaction, sustainability? All of these things are very important part of D&I research, and you can include these aims and these measures as a part of an NIH grant application, for example, or as a part of research that you're already doing in the clinical world. When we think of theories, frameworks, and models, this is often where people start to really scratch their head, really get lost, really get confused. I'm not going to fully clarify it, but I will use some terms that are often used in D&I research and try to distinguish some of the differences between. But when we think of theories, this is a systematic way of understanding events or behaviors by providing interrelated concepts and definitions that explain or predict events by specifying relationships among variables. Specifically, one might ask, what is the scientific basis behind this research? It might be on a theory such as the social cognitive theory, for example. Framework often comes in when we're describing D&I research. We use frameworks a lot within D&I science. That's a strategic or action planning model that provides a systematic way to develop, manage, or evaluate interventions. So, for example, the question of what framework of outcomes would make this implementation successful. We often use CFIR or REAIM as different frameworks, which I'll talk about both of those acronyms in just a moment. And then what model might we use to describe of how to bring together theory and frameworks collectively? And some people use this CMIR, which I'll also talk about in just a moment as well. So again, when we think about the outcomes in this framework, we often use in D&I research, because these are very commonly used and there's ample resources to be able to measure these particular outcomes, we use REAIM, REAIM. So that stands for reach, effectiveness, adoption, implementation, and maintenance. So if you don't know anything else about implementation science or ever care about it, this REAIM, these are outcomes that are very tried and true, bona fide implementation research outcomes that you could incorporate into your research. You would have a basis of why we use that, some validation behind that. So not all of this is nebulous and without research and without publications. REAIM has been utilized, maybe beat to death, if you will, maybe used way too much in implementation science, but is a very common grouping of outcomes that we use in implementation science. Now, where do we measure? What are the domains that we actually measure some of these REAIM outcomes? That is the CFIR. That stands for the Consolidated Framework of Implementation Research. So these CFIR isn't a grouping of outcomes. It's the different places or the people that we will measure these outcomes within. And this might involve the individuals involved, like the patients or the participants in the center of this graphic. So we might measure a number of these things. What was the adoption of the intervention by the individual participants? What was their satisfaction? What was the acceptability of this intervention with the patients that were involved in this clinical intervention study? That is a domain in which we're measuring an outcome. We might study the inner setting. For example, within otolaryngology departments, the otolaryngology department within Johns Hopkins. That might be an inner setting that you're measuring some of these REAIM outcomes. Your outer setting could be all of Johns Hopkins healthcare throughout all of the organization from top to bottom in all the different places, perhaps could be an outer setting in which you're measuring some of these outcomes. So I just want to make sure you understand the difference. And these are some of the core terminologies in D&I science is REAIM, those are outcomes, and CFIR, those are the different domains or places or people in which you measure those outcomes. Make sense so far? Okay. I don't see any heads down on the desk, so I know you're tracking, or at least you're breathing and you're with me so far. This is an interesting conceptual model of implementation research, the CMIR by Proctor, that describes intervention strategies on one side, trying to determine what type of evidence-based strategy or practice we want to test, and then how do we implement this, maybe through different methods, in the second box. And then the red outline box talks about some of those outcomes. REAIM could fit within that box of implementation outcomes, but you can also consider other types of outcomes that you can measure as well. So this is just a way in which we have conceptualized the development and integration of clinical research interventions, how we implement that, and then what types of outcome measures within implementation science that we might gather. If we think about some of the methods and ways that we measure these D&I outcomes, again, there's a number of different ways depending on what you want to look at. We are often in my own research, I'm measuring acceptability, and you can measure acceptability through lots of different ways, whether that's a qualitative interview or through some type of questionnaire. There are brief questionnaires that can be used. Fidelity of the intervention or the feasibility or adoption of that type of intervention. For example, what's the number of program components or intervention locations that adopted delivery of this type of intervention? So there's different methods to be able to assess that. Again, through two other outcomes like reach or penetration, multiple tools, multiple methods to be able to evaluate that. So you can work with a D&I scientist. Ideally, I certainly have to try to formulate ideas and plans for how are we going to measure that? What's the best way to do this? Granted, we don't want every single research participant in our studies to be questionnared to death and have, tens or hundreds of hours worth of questionnaires to complete. There's a number of different things that can sort of measure these things quickly and conveniently for researchers as well as their participants. So now let's shift from the key concepts section of the presentation to talk about how do we actually design a D&I focused or D&I sensitive research project to address some of our health disparity gaps. I think it's important to consider this particular framework or this graphic here of ask yourself, what question are you asking and what type of evidence do you need to be able to change practice, to change population health, to change policy? And then come to the question of what design do you need? Sometimes we're coming to our design because we think, well, I have to do an RCT because if I don't do an RCT, my grant won't get scored and my grant won't get funded. That's a very important pragmatic sense to think about research. So don't ignore what's fundable and what's feasible in your research trajectory, but consider these higher concepts that get to the overall meaning and the value of your research of what is the question you're actually asking and what type of evidence do you want to be able to find. And D&I science can fit within any one of these types of clinical research designs, whether that's an RCT or a pragmatic clinical trial. A step wedge design is something that we've used, or a waitlist control design has been used multiple times, interrupted time series. We'll spend a little bit more time talking about hybrid implementation and effectiveness designs during this presentation. What is a hybrid design? So what this might do is compare implementation strategies potentially. That might be one possible method. What are the ways to disseminate this evidence-based intervention for primary care providers? Is it through a webinar, or is it something through their EMR that requires them to click a box or to disable an alert? Different ways to implement research interventions. What it can do is address the limitations of stepwise research. It can kind of speed the process of collecting some effectiveness data on the clinical outcome while simultaneously collecting implementation science outcomes. It does promote external validity and blend effectiveness and implementation. This diagram describes three different types of hybrid effectiveness implementation research. So in a very clear sense, those of us that are a little nervous, a little skittish, a little uncertain of what D&I science is and how it fully can be used often stay on the left side of this graphic, being in more of the type 1. Those that are hardcore and D&I until I die go into as far as the hybrid level 3. I am a dabbler. So I am a hybrid type 1 type researcher. So what is a type 1? Type 1 is majorly an effectiveness study. Okay, so you're doing an interventional clinical trial through some type of design. You're measuring a clinical outcome. You're going to, present a p-value, confidence intervals to look at what was the clinical effect that was obtained by this intervention. And simultaneously, maybe in an aim two of a research proposal or grant, you are evaluating implementation outcomes. That's exactly what my RO1 looks like, is an effectiveness aim one and an implementation aim two. Okay. Um, Type two is a little bit more of an even blend of, yes, you're going to still measure and test that clinical outcome, but your aim one is probably primarily an implementation aim. You're going to focus more on all of those key types of outcomes across different domains of that CFR or consolidated framework um, of implementation research. And then probably having an aim two as a clinical effectiveness aim. Okay. Type 3 may not have anything to do with clinical effectiveness whatsoever. You may not be measuring hemoglobin A1C or blood pressure or change in decibels or adherence to attend a clinic appointment as a behavioral outcome. You are primarily looking at outcomes focused on just implementation overall. Okay. A further description or breakdown of the design characteristics, the research question, unit of analysis, and primary outcomes can be seen here. I think one of the most important things is look at the row where it says question. If I'm doing a type 1 hybrid effectiveness implementation study, my question is treatment effective versus usual care? Well, that sounds like a clinical trial, a clinical research study that I know and I love. That's great. That's safety. You're sort of grounded on what you're familiar with type 1. But along the way, you can still measure implementation. Type 2 asks a question: is treatment delivered through tailored provider education effective versus usual care? So you see, you're doing a tailored provider education. That's the way you're trying to implement this research, and you're going to measure things related to the tailored provider education about delivering that intervention. And then thirdly, does tailored provider education versus a standard way of notifying providers about an intervention, what makes the difference, or what's the difference between those two? And so again, your unit of analysis will differ, your primary outcomes differ from a health outcome in type 1 versus the uptake of those providers in the type 3. So I'm much less familiar, in full disclosure, with type 3. It has value, it has meaning in all of the D&I world, but a lot of us that are new to D&I science have found type 1 or maybe even type 2s to be the most useful as we begin to implement this. Mixed methods approaches are absolutely critical to understanding the effectiveness of D&I approaches. So I have included in all of my hybrid type 1 trials these mixed methods approaches. And that can involve, pragmatic sense, which are being problem centered, using the best combination or sequencing of methods to help answer the research question. You can have other approaches involving, again, collaborative design of the research together or shared design. For me, it's a matter of just qualitative research is a key study component with almost everything that I do in rural communities. It's really important to continue to hear the voice, to get the words onto the documents and into publication, the words of the stakeholders. That's the providers, community members, the caregivers, the patients themselves. That's a key part of my mixed methods. How do you integrate, multiple forms of data? You can think about this in a general sense, that you might have a quantitative survey that measures behavior and exposure to an intervention. You can also include key findings explained by an interview that you might conduct that further helps to fill in the gaps, which you then verify, look to see if there's contradictions. You can then also incorporate observations and records from the electronic medical record. And then you can have additional clarifications from additional interviews that you conduct. So this is the way in which pragmatically we're conducting a lot of research in hearing healthcare equity to be able to understand how that intervention is being perceived, how it's changing the health outcome, what's the uptake. Okay, we'll finish off now with some practical examples of D&I hybrid research that I'm currently engaged in that hopefully will make it seem a little bit more approachable and a little bit more understandable, perhaps. So I'm going to talk to you first about an example about our patient navigation program that we've developed at the University of Kentucky involving the EDDI system, which is early hearing detection and intervention. This is about infant hearing screening and diagnosis of hearing loss for infants. Patient navigators are trained lay healthcare workers that are used in a wide range of healthcare disciplines, have come historically from the cancer care research background, but how these navigators can provide educational, psychosocial, and logistical patient support. There's a strong evidence to support healthcare utilization with patient navigation in that it can promote those cancer patients completing their chemotherapy or completing their radiation therapy compared to those that were receiving just the usual care. We developed this patient navigation program in 2014 as a part of my K Award. And we focused on using parents who had been through the EDDI system previously, who would contact research participants, parents of children who had just failed a newborn hearing screening that needed to come back to the audiology clinic to get a diagnostic test to demonstrate whether they have normal hearing or if they have hearing loss. And these navigators would provide information about EDDI guidelines and the recommendations for their child to be seen in a timely manner. The standards would dictate that a child that fails a newborn hearing screen would be diagnosed no later than 3 months after birth with hearing loss, or at least by 3 months have a confirmatory test that their hearing is normal. And so we first did an efficacy study in our patient navigation work and demonstrated that overall we were improving non-adherence or these no-shows. The infants that received the patient navigation intervention, 93% of them showed up for their designated follow-up appointment to receive a diagnostic test, compared with the usual care, which was 68%. And the timing even improved. Those that received the intervention were well within the 3 months time frame, about 68 days after birth, compared with the standard usual care, which was 106 days after birth. And we felt like the mechanisms by which the navigation was working was that it was improving the parental knowledge of what the recommendations are, and that that 3 month time point is really critical for them to meet. It's important to know, though, that efficacy does not equal effectiveness. And we did this study in our controlled environment within our academic medical center and included one other clinic that was in our community that was a state-funded hearing healthcare clinic, but really didn't take into consideration the broad context in all of the rural regions and all of the birthing hospitals and rural hearing health clinics out in the community. It ignored multi-level factors. And we don't really understand what are the influences of the implementation of the intervention within those different practices. And when we communicated and talked with our community advisory board, they recommend, let's study this on a larger scale, which was good advice, which we subsequently applied for funding and acquired funding in a study that's known as the CHIRP trial. This is an ongoing trial now. If you're interested in what the study looks like and the protocol, it's published in BMJ Open. It will describe basically how we designed this hybrid effectiveness implementation trial. Remember how I told you about type 1, you might have aim 1 being an effectiveness aim. Indeed, that was our aim. Can the patient navigation intervention promote follow-up to a clinic appointment? That's the health outcome. That's aim 1. But aim 2, using some mixed methodology, we're assessing implementation factors. And then aim 3 of the grant in the study is about evaluating the cost to the state and to the whole system. Notice this in this map of Kentucky, where all of the stars are all of the different locations where the state, where the study is being implemented in throughout the state within a publicly funded hearing healthcare system, not within our academic medical center. So it doesn't involve our center at all. So this is a broader effectiveness trial that includes implementation measures. Notice we're trying to still gather evidence to prove that the intervention works with an effectiveness aim, but we can simultaneously evaluate implementation. This is a diagram of kind of how we've thought about the outcomes related to implementation. It's in the right box that says outcomes. You can see acceptability, adoption, appropriateness, feasibility, reach, and sustainability. And we're measuring all of those in the inner setting within each individual star, each individual clinic, as well as the outer setting, the whole clinic system that is state funded. Okay, so that is bona fide implementation research. Maybe you would say, that just sounds like process evaluation of your research. You know, it's terminology, but it is indeed implementation science. So far, the implementation, the intervention seems to be effective. Overall, in those that are in the standard of practice, during the course of this study, about 31% have a non-adherence rate to come back to the clinic, compared with about 23% that are in a clinic that's delivering patient navigation. Overall, navigation is lowering that non-adherence. The odds ratio is 0.5. There are some differences in follow-up based on different factors, whether it's race or maternal education, that we're further exploring. Additionally, we've done through some of our qualitative research, trying to understand in the voice of some of the parents that have participated in the study, what are some of the factors? And one mechanism is this informational support. One mother of a child that had participated in the study said, she made sure, speaking of the patient navigator, she made sure I knew where the clinic was at, where I was going. She confirmed the appointment time and obviously the place. So we made sure that we were all on the same page so we didn't miss the appointment. And I felt like the appointment was just as important to her as it was to me. So we see that there's some building of trust and there's some connections mechanistically of how patient navigation is making a difference of bringing patients into the health system. Furthermore, these parental perspectives of navigations of what's the method that it's delivered. You know, one parent felt like text messages were the best way. One parent said the text messages are very easy to communicate through, especially with me, because I can respond a lot easier. Another parent preferred phone calls. She said it felt like it made it more personable, that I was actually being heard, that you guys genuinely cared. So I like that a lot better than an email, which just feels more like a corporate thing. And then lastly, you know, about the frequency. One parent said, I probably wouldn't have needed the weekly contact. That was what our study protocol had recommended, as a weekly contact from the navigator. This parent said, I think having one conversation with him or her would have been enough. So we're beginning to understand a little bit more about the dosing that might be necessary, or the methodology of how we are giving this intervention. You can see how these implementation aims and methodologies are giving us more details about what's meaningful behind the intervention. And you might think to yourself, all of this should have been done before you ever did effectiveness research. That's true, but all of that stuff is necessary to do while you're doing effectiveness research as well, because you have a new population, a new setting. You can't rest on your laurels and think that your intervention, once it's done, it can never change. Lastly, I'll talk to you about the Appalachian Star Trial. This is a trial that Susan Emmett, who is an otologist at the University of Arkansas in Little Rock, and I are co-PIs on. But we're studying about how to deliver telemedicine or telehearing screening within school settings. Certainly within Kentucky, but in many states, there are counties that do not have any hospitals, but every single county in Kentucky, at least, has a school, and an elementary school at that. So there are benefits to being able to try to provide some type of healthcare resource within school settings and connect them to specialists. However, there's a wide range of expertise as it relates to the school staff, their healthcare experience, a school nurse, whether there is one or not, and what types of equipment might be there. The goal overall in this type of educational healthcare program would be able to take hearing screening that might occur in a school setting, look at the top leaky pipe, and seeing the leakage that occurs from a screening occurs in a school and the lack of follow-up that might occur for a necessary healthcare clinic, and then moving on to a specialty clinic like an audiologist or to an otolaryngologist, and then furthermore moving to the type of care that needs to be delivered within a hospital or clinic, and trying to fix that leaky pipe by removing a lot of the in between and the barriers to be able to improve the school screening from the beginning, to make some connection with a hearing healthcare provider with the child still in the school, and then know that we're making the right recommendations to get them to the right kind of care moving outside of the school. This research is being done in 14 Appalachian counties in eastern Kentucky, and we're working in these 14 because they all have access to hearing health care free for any child who fails a screen in the school setting within a publicly funded hearing healthcare clinic, kind of in the center of these clusters of counties. But none of these counties have audiologists. None of these counties have otolaryngologists. So they all represent hearing healthcare deserts in a sense. The aims of this research are threefold. One is an adaptation, taking this intervention, this work that Susan has done in other rural populations and trying to apply that for rural America or rural Appalachian schools. We've done some of this adaptation work. And then to do an effectiveness trial in aim two, and then to do through mixed methods approach, do implementation evaluation, again, as a hybrid type one effectiveness implementation trial. And briefly, I'll just share with you that a part of implementation is adaptation of an intervention, which we've done in AIM 1 and even published on, gaining the input of the community members of what does a school-based telehealth program look like. They've recommended care coordination of the screening process, trying to secure the communication that occurs of the screening results as it's sent to parents, educational staff, and even to healthcare providers, and then to provide a comprehensive and timely collection of screening data. It's resulted in us developing these types of interventions. This is the hearing healthcare kit that's used in the school setting. It's a tablet-based program that is connected through the cloud to a firewall-protected educational health system. So as that hearing test is done on that screener, it immediately links through this TrioConnect platform that was developed as a part of our study to link that with their educational record, which can then send out a message securely through the educational messaging system, in the same way that you might receive a message that your child was absent from class today. I get that on occasion. Hopefully it's when my child's gone to the dentist. But it uses that secure messaging system to communicate that information then to the parents, and even can connect that information to providers. So it's improving overall that health system, and it's been the voice of the patients and of the educators, the parents, that's helped us to adapt this type of work. We're now studying the effectiveness of this to promote timely follow-up for hearing screenings after an abnormal screen in the school. Obviously, this type of work involves lots of partnerships and connections, the Department of Education, our Cabinet for Health and Family Services. And lastly, I'm going to just leave you with what are some resources. If you want to bring in D&I work into your lab, into your world, reading is really helpful. Ross Brownson is amazing, incredibly humble, but brilliant D&I researcher who's at Washington University in St. Louis. But he has a second edition of his book about dissemination, implementation, research in health. It really represents the Bible of D&I science. So I encourage you to take a look at this book. And there's other resources. The University of Colorado has a D&I science program where you can actually get a certificate or a master's within some D&I work within their College of Medicine, disseminationimplementation.org. And then there's an annual D&I conference that usually occurs in December. And you can go to academyhealth.org to learn about that conference. So these are all really important ways that you can learn about D&I science. So if you're working with evidence-based interventions, don't give up. You can include D&I work to help you adapt or implement, to evaluate the factors that prevent the use of the intervention. If you're still gathering your evidence, you could do a hybrid trial like I've done, evaluating health outcomes and implementation outcomes together. D&I research is complex, but it's a very collaborative field. This D&I work helps to propel your research into practice and policy change, and it can be done alongside of clinical trials and integrated with it. My advice is to connect with D&I researchers that know lots of more about this than I do and work in this sphere every single day, and utilize some of these D&I resources, such as the Brownson book or the conference that I spoke of, or even some of the educational resources through the University of Colorado. So again, thank you for your time and attention, and I'd be glad to take any questions or welcome a discussion.
Thank you, Matt. Any questions?
Excellent. Really fantastic. Can you hear me?
Yes, I can hear you.
Okay. Well,
There's a microphone there.
Vis-a-vis the fact that the United States doesn't have a national house. So in terms of insurance and so on, how does that work? Dissemination, which channels you use for dissemination?
Yeah, it's a great question. So the complexity of the U.S. health system actually creates a very fertile soil for D&I work to go on, because when you've seen one health system, Kaiser Health, or the UK healthcare system, or the Hopkins healthcare system, you've seen one health system. And so there are needs for us to be able to understand broader approaches that might help bridge some of the differences, but also to find some of the commonalities between our health systems, so we know better how to take what we know is evidence-based and to be able to test it and then promote it as meaningful standard of care practice moving forward. So our health, the lack of a unified or common health system actually really creates a value proposition for why D&I science is relevant.
Thank you.
Thanks for your talk. I'm going to make a couple of quick plugs. We also have a certificate program here in implementation science. Just so the Hopkins folks are at the emails there.
Send me an email and I will add it on my slides and never forget you from this point forward.
And Lakshmi Christina will talk to hear our student group will, and IS student group this year. So I am an implementation scientist, but I come from the HIV field and have recently joined the center to try and help think about ways to incorporate D&I science more. So this is a great talk.
Did I botch it up? Did I embarrass you or your field? Oh, thank you. I am so relieved.
It's time to the hearing space. Like, some of your thoughts on where the untapped opportunities for more implementation science and more implementation strategies within that space. Any of your hot takes there?
I think what's most critical for hearing healthcare providers, clinicians that are engaged in clinical research, is knowledge base, is education about what is D&I science, what it's not, what are the means for funding, what are the ways to integrate it into your research portfolio. I think collaboration, not to do everything that you do and more, but to know how to find commonalities and collaborations together are secondly really important. And then thirdly, I think we need more hybrid trials that simultaneously are evaluating effectiveness, that are assessing our devices or behavioral interventions, along with implementation measures, so that we hopefully can move through that translation process faster. So I think the work that you're doing with the certificate and what you're doing to teach courses is critical, but I think otolaryngologists, otolaryngology residents and fellows, audiologists, are all need to be, students in those classes and learning on the content. What else? Any other questions?
Great. Thank you very much, Matt. And thank you for everybody joining us online. We'll see you back here in February. Thank you.